Bismillah ar-Rahman ar-Rahim. This is Dr. Ahmad Al-Farouq Abdel Fattah. I am an ENT professor in Cairo University, and I will discuss with you in this lecture some of the nasal symptoms and nasal searches. Actually, we will focus today on rhinorrhea, smell disorders, headache, and proptosis, in addition to some important nasal searches. Actually, nasal symptoms are very important. Why they are important? Because in case we are able to take good history taking, we will be able to reach diagnosis in most cases of the nose and paranasal sinuses. So, if we analyze our symptoms well, and if we study our differential diagnosis well, in most cases we can reach provisional diagnosis, which is usually the correct diagnosis. We can build on this and we can continue our management plan. We can do our investigation. We can use nasal endoscopy and CT scan, sometimes biopsy. Then we can reach the sure diagnosis and start our treatment plan. We have many nasal symptoms. The most common and most important symptoms are the first two, nasal obstruction and nasal discharge. We have also bleeding per nose, epistaxis. We have smell disorders, facial pain and head, sneezing, snoring, proptosis, mouth breathing. We have many symptoms. The most common and most important first two, nasal obstruction has been discussed before in another lecture. So we will focus on nasal discharge. To analyze nasal discharge, we will discuss onset, course, duration of the discharge, unilateral or bilateral discharge. Is it important? Yes, it's very important, because this is completely different differential diagnosis. Okay, is it persistent or intermittent? What are the association with this discharge? Is it associated with nasal obstruction or headache or facial pain, or what symptoms are associated with us? Is it anterior or posterior discharge? What is the nature of the discharge? Is it mucoid, or is it bleeding, or is it mucopurulent or watery discharge? And what is the response to treatment? Many things to analyze this discharge. So, what are the different causes of bilateral nasal discharge? This depends on the nature of the discharge. We have watery discharge, we have bleeding per nose, mucopurulent or purulent discharge, nasal regurg of food or fluid, and rusty discharge. Watery discharge will happen in allergic rhinitis, vasomotor rhinitis, sometimes with excessive lacrimation, like common cold, acute rhinitis. Because, of course, we know that the lacrimation of tear will be washed away through the nasolacrimal duct that will open in the inferior meatus below the inferior turbinate. We have, of course, blood, which is epistaxis. This is a completely different topic with different causes. Might be general or local causes. We have the mucopurulent or purulent discharge in all causes of nasal obstruction, because nasal obstruction will predispose to infection, because there is no aeration. This will make the possibility of sinusitis and the resulting mucopurulent discharge. We have nasal regurg of food and fluid in cases of cleft palate or perforation of the hard palate, like in cases of syphilis, or paralysis of the soft palate. like bulbar pulse. We have cases like atrophic rhinitis and granulomatous stage of scleroma, and cases of septal perforation that might lead to crustation. Here we can see an endoscopic view showing the middle meatus, and here we can see how it looks like to have a mucopurulent discharge. And mucopurulent discharge means, of course, sinusitis. And mucopurulent discharge in the middle meatus means sinusitis of the anterior group of the paranasal sinuses, and I mean the maxillary and frontal and anterior ethmoid air cells. Here we can see again mucopurulent discharge of the middle meatus of the left side of the nasal lavage. Again, this means infection of the paranasal sinuses, rhinosinusitis, and here you can see how it looks like on the other side. What we can see in this picture? This picture, of course, is CT of the paranasal sinuses. We can see here the maxillary sinuses on both sides, and we can see the ethmoid air cells. Here we can see the ethmoid looks black in between the eyes, and this is normal. And here you can see on the right side the left maxillary sinus, which looks black, and this is normal. And we can see on the other side the right maxillary sinus, which is not black. You can see the white coloration. This means opacification of the right maxillary sinus. Okay. On our left side, this is the right maxillary sinus, because we always consider the sinuses, the CT, as if the patient is sitting in front of us. So my left hand will be his right side and vice versa. So we can see the right maxillary sinus of the patient opacified in the CT. And this is for differential diagnosis. It might be retained secretions, it might be thickened mucosa, it might be polypi, it might be masses, and so on. Usually, or in such case, we can see that this looks like secretions because we have transverse upper level, and this usually means maxillary sinusitis. So this is right side maxillary sinus opacification for differential diagnosis, most probably maxillary sinusitis. In this view, we can see the adenoidal tissue. This is an X-ray skull lateral view showing adenoids. We can see those arrows pointing to the adenoidal tissue. And we can see that this adenoid is encroaching on the air column, which looks black. We can see the air column in front of the adenoid very, very thin, while below the adenoid it is very large. So the adenoid in this case has been enlarged and encroaching with the air column, causing nasal obstruction. Usually this is bilateral nasal obstruction because this will obstruct the vena, both sides causing bilateral nasal obstruction, and the sequelae of nasal obstruction, mouth breathing and adenoid fascias, and so on. Of course, usually it is associated with secretory otitis media, and of course, such case, I think it is indicated to have adenoidectomy, and if it is associated with secretory otitis media, it will be indicated also for after failure of treatment to bilateral myringotomy and ventilation tubes insertion, which are grommets tubes insertion. Here we can see the adenoid after removal. And usually we put the ruler near us or small syringe to see the calibration. Usually if we remove anything of the body, we have to put something to measure and to relate and to imagine the size of the tumor or of the adenoid. So we can see 1 centimeter, 2 centimeter, 3 centimeters. So we can imagine, because if you look at it alone, you will not. Sometimes you can imagine very big tumor or very small. Here we can imagine this is 3.5 centimeters, and this is an adenoidal tissue, and this is how it looks like, tissue lobulated, and this is the adenoid, how the adenoid looks like. Another X-ray lateral view. We can see here the adenoid, and we can see the air column below. Usually in such cases you will find the head of the question telling you that this is the patient is a young kid and 3 or 4 years old, and the manifestation are so and so and so. Here you usually correlate what you see in the X-ray or the CT with the clinical presentation, and then you take your diagnosis and decision upon all those measurements. Okay, so we have here again enlarged adenoid, and the treatment of adenoid, of course, is antrostomy, and if it is associated with chronic tonsillitis, so it is adenotonsillectomy. If it is associated with secretory otitis media, again this is adenoidectomy and mylingotomy and bilateral grommets tubes insertion. Here we can see, this is, maybe you are not oriented to such view, this is endoscopic view of the guana. And here we can see the adenoidal tissue enlarging and is getting very bigger, reaching the guana and expanding through the guana to fill it and close it and go inside the nasal cavity, causing absolute and complete nasal obstruction of this side. So we can imagine such kid with severe nasal obstruction, possibly obstructive sleep apnea, nasal tone of voice, mouth breathing, and all the sequelae of mouth breathing. So after we finish examples for bilateral nasal obstruction, here we can see unilateral nasal obstruction. What are the differential diagnoses for unilateral nasal obstruction? Of course, many students are using congenital traumatic inflammatory neoplastic miscellaneous. Okay, that's okay. But of course, you should know that the common things are very, very important, and the serious cases are very, very important also. So if you do not mention the most common things and most important things, you will lose big part, of course, of the mark. So we should be oriented that common things are important and serious things are very important. Okay, so what are the possible causes of unilateral nasal discharge? We have unilateral choanal atresia. Unilateral choanal atresia. Is it important? No, this is congenital. Okay, we start by congenital. It's okay. It is not that common and it is not that serious. Okay, but this is one of the differential diagnoses. Unilateral sinusitis. Okay, causing mucopurulent discharge, purulent or mucopurulent discharge. Okay. Then we have watery discharge. watery discharge. Watery discharge means I should suspect something which is very, very, very important. That's why I have to write it in a big letters. I have to put different colors. This is very serious and this is very important. Okay, so here we can tell that this we should focus on this and we should give this some concentration. So whenever patient is coming to me in the clinic telling me I have unilateral nasal obstruction, I should be alert. Unilateral nasal obstruction. What is the unilateral nasal discharge? Unilateral nasal discharge. So what is the nature of this discharge? Is it mucopurulent or purulent or blood? It is watery discharge. So I am talking about unilateral nasal obstruction, unilateral nasal discharge, which is watery discharge. Of course, he did draw my attention. Then I have to ask him, do you have any history of trauma? Did you have any accident? Trauma to the head? Did you have nasal surgery? That's how I can deal with the patient. This is how I should suspect something very important. So I did not touch the patient yet, but now I can know that there is something that might be very serious to the patient. CSF rhinorrhea, it means this patient is exposed to have meningitis or any intracranial infection. This is very important. Maybe the patient is not oriented, but here is our rule, and here is the importance of studying well our history, our symptoms, our differential diagnosis, and so on. So watery nasal discharge, which is unilateral, will draw our attention to CSF rhinorrhea, and here I can complete my investigation. I can ask for CT, high resolution CT. I can ask for MRI cysternography. I can ask for intrathecal dye. I can do many things. I can do investigation and analysis for the watery discharge, beta-2 transferrin test. I can see the glucose content. Okay, I can search for the defect in the skull base that might be the source of the CSF, and so on. And then I can continue my management plan. I did start in the correct way so that I can continue in the correct way. We have different causes of unilateral nasal discharge. If the discharge is food and water, I might have oroantral fistula. We have, of course, epistaxis. We have the mucopurulent discharge that happened with all the causes of unilateral nasal obstruction, because unilateral nasal obstruction causes aeration, and this might lead to sinusitis, of course, or rhinitis, and mucopurulent discharge. We have atrophic rhinitis with its crustation, and we have tumors, and we have foreign body. Foreign body is a famous case. That you have foreign body, of course you have foreign body will be in infant or kid or mentally retarded patient. When we have foreign body, so I have when should I suspect foreign body? When I have unilateral nasal discharge in an infant or mentally retarded, and the discharge is very, very offensive. Usually you can smell the offensive discharge before you see the patient, just after the patient enters your clinic. So it's very famous case, unilateral offensive nasal discharge in 4 years old, 3 years old kid. You should suspect foreign body. Then you ask for the history. Sometimes it is apparent to the parents, sometimes not. But then comes the role of the examination, of course. But anyway, by the history, by evaluation, you suspect something important, then you can go for it, of course, and continue your management to the patient. Here you can see examples for cases with foreign body. Here we can see different foreign bodies in endoscopic views. Here we can see unilateral nasal discharge. Can you see the drop? Can you see the drop is coming out of the nose? Of course, you can see it. It is yellowish in discharge. It is yellowish discharge. This is because we inject fluorescein, and this is the color of the discharge with fluorescein. If we have endoscopic view after injecting intrathecal fluorescein, we can see the CSF stained like this. Here we can see with the what's called blue light effect. Here we can see different case. We can see deviated nasal septum. The septum is S-shaped, and we can see the maxillary sinus opacification. The other maxillary sinus is black. This means air. This means normal. And here we can see maxillary sinus opacification. Again, maxillary sinus opacification, this is for differential diagnosis. Differential diagnosis means we might have secretions, we might have thickened mucosa, we might have polyp, we might have a tumor. So we have maxillary opacification for differential diagnosis. Getting to another symptoms, what's called postnasal discharge. Many patients are coming to our clinics complaining of postnasal discharge. We have the nasal discharge coming anteriorly from the anterior nares of the nose, and we have postnasal discharge, which is the discharge that coming from the nose, getting posteriorly into the choana, and from the choana getting into the nasopharynx, then the oropharynx, then getting down. This is an irritating symptom. The most common causes of postnasal discharge are, or the most the common sequelae of the postnasal discharge are irritative cough. It might lead to laryngitis or pharyngitis, here what's called descending infection, and gastric troubles, of course, because this discharge will be swallowed later, causing irritation of the stomach. The causes of postnasal discharge, sometimes due to sinusitis, this will be mucopharyngeal discharge, sometimes due to allergic rhinitis and exaggerated response of the mucosa, and sometimes physiological postnasal discharge. What about smell disorders? First of all, for perception of odor, we need three factors, three things. First of all, the particle. The particle which is getting in contact with the olfactory mucosa, the particle with the odor. And then we need healthy, moist mucous membrane to dissolve this particle inside. Then we need the normal nerve endings and olfactory terminals. So the impulse will get through the nerve into the olfactory pathway, then we can feel the sense of smell. We have different types of smell disorders. is not as you might imagine. Smell disorders mean loss of smell or weakness of smell. No, we have different kinds of smell disorders. We have anosmia or hyposmia, we have cachosmia, and we have parosmia and hyperosmia. What is hyposmia or anosmia? Anosmia means, of course, loss of sense of smell. And hyposmia means decrease in the sense of smell. This is by definition. What are the causes of smell disorders in the form of anosmia or hyposmia? According to the previous factors, any interruption of those factors will lead to abnormality of smell. If we have anything intranasal that causes blockage of the nose, so the reference particle will not be able to assess and go to the olfactory area. One of the most famous causes of nasal blockage, allergic nasal polypi. So if we have allergic nasal polypi clothing the nose completely, so we will not be able, of course, to have our smell. Atrophy of the mucosa in cases of atrophic rhinitis or peripheral neuritis like influenza or diabetes mellitus. Anything that might interfere with the nerve ending or the nerve might affect, of course, the sense of smell. We have intranasal causes like congenital abscess of the olfactory bulb or the olfactory nerves. We have compressed cortical centers or cortical fibers by tumors. We have basal meningitis. Different causes which are intracranial that might affect the olfactory pathway. We have psychogenic. We have the psychogenic cause, hyposmia. We have cranial cause like fracture base or clavicle plate. Those are the causes of hyposmia. Here we can see example. This is an endoscopic view showing a case of atrophic rhinitis. Here we can see the crustation, which is a very important phenomena for atrophic rhinitis. Atrophic rhinitis means atrophic stage of rhinoscleroma or atrophic rhinitis. Getting to another smell disorder, which is cachosmia. Cachosmia is perception of bad odor. This is very famous this is presented in very famous things like foreign body and sinusitis of dental origin. So in cases of sinusitis of dental origin, there is very bad smell, and of course this is due to the anaerobic organism of dental infection. And getting to another smell disorder, which is parosmia. Parosmia is perverted smell. So perverted sense of smell or getting abnormal sense of smell. This is in cases of neuritis like post-influenzal or hysterical cases of epilepsy or insanity. And we have also hyperosmia. This is increased in the hypersensitivity to odors. This is in any lesion irritating the olfactory bulb. Those were the smell disorders, and here we can get to another important symptom, which is proptosis. What is the meaning of proptosis? This is forward displacement of the eyeball. I mean protrusion of the eyeball. The direction of the proptosis is very, very important. Sometimes the eye is protruded in downward and lateral position. Sometimes in lateral position. Sometimes in forward position or upward position. This is very important because this will lead us to think that something is compressing the eye from the opposite direction. So here we can suspect the pathology that might cause the proptosis. Here we can see an example to the right eyeball, which is which has proptosis in the downward and lateral position. Here we can see how the mucocele will compress the right eye. And we know that it is the right eye from the letter R that is written here. Okay, so we have mucocele and compressing the eyeball. But this case is very, very, very serious. Why? Because we can see that this mucocele is compressing the optic nerve. And if the optic nerve is compressed, so the vision is in danger. So we have to interfere in such case, and we have to do our treatment very quickly. And the treatment in case of mucocele is endoscopic sinus surgery. And endoscopic surgery, we have to do what's called marsupialization of the mucocele. That's to open the mucocele and evacuate the collection and remove part of the wall of the mucocele so that it will not recollect again. Again, you can see something compressing the right eyeball downward and laterally. What are the possible causes of proptosis? We have causes in the paranasal sinuses, like frontal mucocele or osteoma. Frontal sinus is above the eyeball, so if it compresses the eyeball, it will be directed downward. So this is downward proptosis. While if the pathology is in the ethmoid air cell, like ethmoidal mucocele or ethmoidal malignancy, it will cause lateral proptosis of the eyeball. If it is frontoethmoidal, coming from the medial and above, so the eyeball will be directed downward and laterally. Frontoethmoidal mucocele. Any cases of maxillary tumors will cause compression of the eyeball and push it in the upward direction. We have another causes, like in the lacrimal gland. It will cause downward and medial proptosis because the lacrimal gland is located in the orbit in the lateral up position, so it will push the eyeball downward and medial. We have causes in the orbit causing forward proptosis, like cellulitis or abscess or tumor in the orbit, or any hematoma or collection. We have causes in the nasopharynx, like angiofibroma or carcinoma of the nasopharynx. We have cavernous sinus thrombosis. This causes what's called pulsating proptosis. We have endocrinal causes like toxic butter. Okay? Of course, the treatment of the proptosis is to find out what is the cause of proptosis and to deal with such cause carefully. So you treat the cause, and the treatment depends on the cause of the proptosis. Here we are getting to headache and facial pain. The mechanism of headache is traction or distension of pain-sensitive structures, which are dura of the skull base, cerebral arteries, venous sinuses, cranial nerves like 5 and 9 and 10, trigeminal, hypoglossal and vagus, or cervical, C2 and 3. We have extracranial causes and intracranial causes like meningitis, brain tumor, head trauma. The extracranial causes are nasal causes or oral causes. Nasal causes like different types of infection, sinusitis, tumors. Of course, the headache of nasal origin have some important characteristics. It is usually increasing in the morning after waking up, and it is usually increased on leaning forward and increased by coughing. It is called vacuum headache. Vacuum headache is due to suction force, negative suction force, due to blockage of the aeration of the sinus, and the air is getting absorbed inside, giving way to what's called vacuum headache. Of course, we have the contact headache due to contact between the nasal septum and the nasal turbinates. We have oral causes of headache, like tumors. We have malignant tumors or glomus or acoustic neuroma. We have also complicated otitis media, otitis externa, acute suppurative otitis. We have ocular causes of headache. Usually, headache due to ocular causes increase at the end of the day because we have been using the eye all over the day, causing exhaustion to the eye, and usually the headache increases by the end of the day. Of course, it is very famous with big errors of refraction and causes with astigmatism, causes of cases with glaucoma, cases with tumors or orbital cellulitis or abscess, of course. We have dental causes of headache. This is very famous, of course, dental caries and infection and post-extraction neuralgia. We have what's called cervical spondylosis. We have what's called TMJ arthralgia, temporomandibular joint arthralgia. Here what's called Castle syndrome. Okay, this is usually associated with temporomandibular joint pain, deafness, and tinnitus. Here we can see patient with orbital cellulitis. This is sometimes as a sequelae of sinusitis, or sometimes for different causes. We have, among the extracranial causes of headache, neuralgia. We have trigeminal neuralgia or glossopharyngeal neuralgia. First, regarding trigeminal neuralgia, the site of neuralgia is the upper or middle or lower third of the face, according to what branch of the trigeminal is affected, the ophthalmic or the maxillary or the mandibular. Usually the stimulus is something like toothbrushing. The cause is vascular lobe that compress the nerve, and the treatment is tegretol or surgical treatment. Surgical treatment aiming to decompression of the lobe, or trigeminal neurectomy, or trigeminal ganglion alcohol injection. We have also what's called glossopharyngeal neuralgia. Okay? It is also related to the swallowing due to long styloid process, and the treatment is tegretol. Sometimes we need, in persistent severe cases, we need to fracture the styloid process or glossopharyngeal neurectomy. Among different causes of headache came the migraine. Migraine is a very famous headache. It's due to or characterized by it is very recurrent, and it is preceded by aura. What's aura? Some manifestation that just precede the headache. So when the patient is exposed to such manifestation, he knows that the headache is coming on. Usually the aura is of flashes of light, or sometimes with different characters. Usually, of course, the headache is due to vasoconstriction, which is followed later by vasodilatation. So it's a kind of vascular headache. Of course, it's one of the severe types of headache, and the treatment of is ergot and caffeine and different anti-migrainous drugs. We have general causes of headache like hypertension. Hypertension, high blood pressure is very important cause of headache, and it is very, very severe headache, of course. We have some different causes like constipation. Of course, we have malignancy, infection, toxemia, many things that might affect the general condition and result, of course, in headache also. Different manifestation, mouth breathing. Mouth breathing. What are the causes of mouth breathing? They are the causes of nasal obstruction. As long as there is nasal obstruction, so the patient will be forced to breathe through his mouth. And of course, the mouth is not the organ that is came for breathing. The breathing should be through the nose and the airway. So whenever we have mouth breathing, we will have a sequelae like ENT complaints or ENT complications. We have nasal problems like rhinitis or sinusitis. We have nasal tone of voice, what's called rhinolalia glossum. We have obstructive sleep apnea. This is very important. Sometimes it's associated with smell disorders or difficult suckling. We have oral and pharyngeal complications like dry mouth and infection. We have laryngeal and pulmonary complications like pigeon chest and descending infections. We have what's called adenoid facies. In cases of prolonged obstruction due to adenoidal hypertrophy, here comes the adenoid facies. We have general complications like hypoxia, hypercapnia, sleep apnea syndrome, different sequelae coming from mouth breathing, because we should have our breathing through the nose. And this is abnormal, that's why it leads to this abnormal sequelae, as we saw today. Here, after we finish some of the symptoms to be discussed, we are going to nasal surgery. What about nasal surgery? Before I start my nasal surgery, I should know that we have requirements that should be fulfilled to do a successful nasal surgery. First of all, I should prepare myself. I should have good illumination. Illumination can be from headlight, can be from light source and connected to the endoscope. Sometimes operating microscope. I think not anymore now, but the surgery has been done before using the operating microscope. Endoscopes, we will use endoscopes either 0 degree or 30 degree or 45, 70 or 90. Different kinds of endoscope, and we will see together now what are the difference between them. Of course, I should have good hemostasis and good suction in order to be able to see very well and to do the correct steps. Of course, I should have very suitable and very good instrumentations to be able to do my surgical steps. Here we can see what's called nasal speculums. The small one, the lower one, is called phodicum, and this is nasal speculum which is used for nasal examination or anterior rhinoscopy using headlight and anterior rhinoscopy. The other one is called nasal speculum or Killian speculum for surgery. This is used in cases of septal surgery or nasal surgery. So the lower one is nasal speculum for examination. The upper one is nasal speculum for nasal surgery. On the left side, we can see the flexible endoscope. Flexible endoscope is not used for the nose and sinuses. It is used usually for laryngoscopy, examination of the vocal cords and examination of the larynx. While the right one is rigid endoscope. This is the one that we might use in diagnosis of nasal case or treatment through endoscopic sinus surgery. Here we can see it is connected to what's called camera, so that it can be projected on the monitor and we can see the view very clearly in the monitor. And it is very good, of course, for learning and for following on the patient or for surgeries. Again, here we can see the upper one is the flexible endoscope, and the lower one is the rigid endoscope that we can use to do our endoscopic sinus surgery or to examine the nose and paranasal sinuses. Sometimes I have what's called 0-degree endoscope. 0-degree endoscope can see what in front of the endoscope. Sometimes I have the 30-degree that will see in a 30-degree. So this endoscope will not see what in front of me, it will see what is 30-degree to me below me. And we have 45 that will see 45-degree below, 70 and 90-degree. So sometimes I use the endoscope and I go inside the nose, but I will never see the things in front of me. I will see things below. So I can get this 90-degree and go through the oral cavity and have a look to the vocal cord and larynx, for example. Sometimes I can rotate this 70-degree or 90-degree so that I will see things above. So I can use the endoscopes with angle like 45, 30, 70, so that I can see things that are hidden and I cannot see by using those angles. And this is how we can do surgery in the maxillary sinus or the frontal sinus, for example. So when I am using the 0-degree, I can see what is in front of me. But when I use 30-degree, 45, 70 degrees, I can see what's on the right side and can rotate it to see what's above and so on. And here the meaning of 0-degree endoscope and 30-degree and 45 and 90. Inferior meatal antrostomy. This is an old kind of surgery. Inferior meatal antrostomy. Meatal antrostomy is to make an opening in the inferior meatus. This opening. Okay. Here we can see the inferior turbinate. Here we can see the septum. Okay. And here we can see the maxillary sinus opening in the inferior meatus. The indication to take biopsy from tumor in the maxillary sinus or to remove secretion or to wash the maxillary sinus. This is old surgery, not used nowadays. Why? Because this is against the mucociliary clearance. What is meant by this? The normal physiology of the nasal sinus and the mucociliary clearance, the cilia inside the maxillary sinus is pushing the mucous blanket toward the natural ostium of the maxillary sinus, which is located upward and will open in the middle meatus, not in the inferior meatus. So if I open an additional ostium in the inferior meatus, the mucus will not get out from the discharge, and the sequelae will not get out from this ostium, and it will be directed to the natural ostium that will open above in the middle meatus. So this will help recirculation of the mucus, and this will lead to sinusitis, recurrent sinusitis, and so on. So this is not good surgery, that's why it is not done nowadays. Of course, it might cause nasolacrimal duct surgery, sphenopalatine artery surgery, infraorbital nerve surgery if we are getting a little bit upward, and sometimes it causes closure and fibrosis. Of course, it's the contraindication if we have sinusitis or bleeding tendency, and again, I'm telling you, we are not doing such surgery now. Here we can see another example. We can see the maxillary sinus after making inferior meatal antrostomy. You can see the inferior turbinate and nasal septum. Here is the trocar that might be used to do this surgery. And here we can see after making our opening, here we can see in the CT the site for maxillary antrostomy. Puncture and lavage of the maxillary sinus. This is to wash the maxillary sinus, to have culture and sensitivity in cases of chronic rhinosinusitis, and to take cytology in cases of the tumor of the maxillary sinus. Possible, of course, complications: hemorrhage, false passage leading to swelling in the face or the eye, complication, of course, of surface anesthesia. Also, again, I will tell you that we are not doing such surgery. Here with this diagram, how we insert the cannula inside the maxillary sinus and push the fluid to get outside from the natural organ. Again, we can see the diagram, how the trocar is inserted and the pathway wash. Of course, X-ray paranasal sinus is not used anymore in our nowadays, and it is replaced, of course, by the CT paranasal sinuses. But when we are using the X-ray before to detect sinusitis and wash, here we can see what's called trocar and cannula. We insert the trocar and cannula, then penetrate and then leave the cannula and push the fluid inside. Here we can see the radical antrostomy, what's called Caldwell loop surgery. Caldwell loop surgery is indicated to remove foreign body from the maxillary sinus. Also, closure of oroantral fistula, remove large antroquinal polyp, and clean the site of origin very well. Removal of nasal cyst, maxillary cases of persistent maxillary sinusitis, biopsy from maxillary sinus tumor, and treatment of fracture of the maxilla. Of course, I have to tell you that it's very, very, very rare nowadays, of course, again, to do such surgery. This is because of the advances in the instrumentation and the endoscope, and the gaining more experience with endoscopic sinus surgery is very, very rare to need such open interference. The complication: infraorbital nerve injury, oroantral fistula, sphenopalatine artery injury, and nasolacrimal damage. Here we can see the diagram to show the site of the opening in cases of Caldwell Lux operation, and here we can see we remove sublabially and we open just above the teeth, and then we remove the anterior wall of the maxillary sinus surgically to expose the maxillary sinus and deal with any pathology inside the maxillary sinus. Again, we can see on the right side external frontoethmoidectomy. External frontoethmoidectomy. The indications in cases of chronic frontal sinusitis with obstruction of the nasofrontal duct, chronic ethmoiditis in cases of osteoma, benign tumor like osteoma, in cases of mucoceles, in case of acute ethmoiditis or abscess, ligation of anterior ethmoidal arch. All those indications can be done nowadays endoscopically. And as long as I can do them endoscopically, so there is no need to make an open surgery, and the morbidity and the healing and the aesthetic part will lead us to use the endoscopic nasal surgery. The complications of external frontoethmoidectomy, orbital hematoma, diplopia, discomfort, of course, due to drainage tube. Sometimes we use for the frontal sinus, and persistent symptoms or failure of surgery. So this is possible. Here we can see the site. We are marking the site for external frontoethmoidectomy. Turbinectomy. Turbinectomy is one of the famous surgery for the ENT surgeon. We have different kinds of turbinectomy. Of course, to do turbinectomy, we can do it, or we need to do it when there is hypertrophy of the inferior nasal turbinate. Hypertrophy of inferior nasal turbinate. We should know that the turbinate is a kind of spongy tissue, that sometimes it increases in size, sometimes it decreases in size. Okay? Some cases that will not respond to treatment, we will need to do what's called turbinectomy. We have surgical turbinectomy, but this might lead to atrophic rhinitis or post-operative hemorrhage. We should preserve the anterior part. We should preserve always the anterior part, and if we are going to remove, we only remove the posterior part, because this is the most narrow part of the nose, and it is very easy to close the guena of the nose. So we remove the posterior part and keep the anterior part to avoid what's called atrophic rhinitis, because it's very difficult to treat atrophic rhinitis. There is another methods to do turbinectomy than to do it surgically. We can use this scissor and do it surgically, and we can use different methods like submucous diathermy, and we can use laser, we can use what's called radio frequency turbinectomy, ablation, and we can use shavers, micro debriders. Okay? We can use also, so we have surgical, we have submucous diathermy. Submucous diathermy might lead to crustation, adhesions, and recurrence of symptoms after a while, and epistaxis. The most important complication of turbinectomy is epistaxis, because it's kind of vascular tissue, and it can easily bleed during surgery, just after surgery, sometimes after removal of the pack, sometimes after removal of the pack after 1 week, and even till 2 weeks. So this is the most important complication that we care about in the cases of turbinectomy, the bleeding. Okay? So you should be very careful whenever you are doing turbinectomy, and you should have a very good look by the endoscope for the sites of bleeding, and you can use the bipolar diathermy or whatever to control bleeding and to be sure that there is no site of bleeding for this turbinectomy. Here we can see how we are using the scissor to do our turbinectomy. Here we can see CT of a case after inferior turbinectomy. Whenever you are doing the turbinectomy and we remove the whole turbinate, we are confronted to what's called roomy nose, and this case with atrophic rhinitis, which is very, very bad, because the nose is very, very big, the nasal cavity is very big, but the patient still cannot feel the air anymore because there is no nerve ending, and there is frustration, and this is a very bad case to treat. It is not easy to treat a case of atrophic rhinitis. Here we can use the radio frequency or another surgery of the nose, the rhinoplasty. Of course, the rhinoplasty is a plastic reconstruction of the nose. It can be used to correct nasal deformity or deformity in the septum, and here it can be called septorhinoplasty. Of course, it is contraindicated in psychic patients because they will never be satisfied, and it's not correct to operate for such patient, and patient with unreasonable expectations, of course. The complication of rhinoplasty, edema or adhesions, persistent deformity, patient unsatisfaction, and bleeding. Here we can see on the left side patient with nasal hump, and on the right side after correction of the hump. This is rhinoplasty. We have submucous resection of the nasal septum, one of the most common surgeries for the ENT surgeon. Submucous resection of the nasal septum is to remove the nasal septal cartilage and the deviated part of the bone of the septum. Of course, the indication is deviated nasal septum. Any kind of deviated nasal septum? No, of course. Symptomatizing deviated nasal septum, persistent nasal obstruction, sometimes with sequelae like sinusitis. Contraindication before the age of 18 years. Why? Why it is contraindicated before the age of 18 years? Because it will interfere with the growth of the middle third of the face. So usually if we find some nasal septal pathology, it's better to wait until the age of 18 years, and if it is severe pathology or with severe sequelae, we can do what's called septoplasty, but the submucous resection should be never done before the age of 18 years. And this is very important. The technique, of course, under general anesthesia, we do vertical incision. We do vertical incision in the anterior part of the nasal septum, here. Okay? Then we elevate the septal flap from the septal cartilage. So we have mucosa and cartilage. Then when we incise the cartilage to reach the mucosa on the other side. Then we dissect the flap between the cartilage and the mucosa of the other side. So we have mucosa, cartilage, mucosa, and all dissected from each other. Then we can remove the septal cartilage, but we are keeping the upper part to support the nasal bridge and the anterior part to support the nasal lip. So we remove the whole cartilage, keeping only support anteriorly and superiorly. Then we reposition of the mucoperichondrial flap and take our sutures to close the incision and do our packing for 48 hours. This is submucous resection of the nasal. The septoplasty is to straighten the septum with or without minimal cartilage removal. Indications: deviated nasal septum or anterior dislocation of the nasal septum. You can see here the anterior dislocation of. Of course, the technique, general anesthesia, usually incision at the anterior end of the nasal septal cartilage, elevate the mucoperichondrial flap or flaps according to the situation. Then you can straighten the cartilage by separation the cartilage from the maxillary crest downward, or separation backward from the vomer bone. We can remove the minimal parts of the cartilage, keeping the mucoperichondrial flaps healthy on both sides. Then we reposition the flaps and do our packing. The complications of nasal septal surgery: perforation of the septum when we have tear in one side in the mucoperichondrial flap and tear in the other flap in the same side, and it is more, of course, in submucous resection of nasal septum. We have supratip depression if we remove the cartilage anteriorly, only in case of submucous resection of the nasal cartilage. We have possibility of hemorrhage or hematoma collection. Sometimes we have infections like sinusitis, septal abscess, or adhesions. Sometimes we have CSF rhinorrhea or anesthetic complication. Here we can see an endoscopic view of nasal septal. Nasal endoscopy. Nasal endoscopy, we can use it for diagnostic purposes or therapeutic. Diagnostic endoscopy is indicated in cases of chronic rhinosinusitis, polyposis, choanal atresia. Of course, in choanal atresia, we'll never be able to see the atretic plate unless we use the endoscope and getting deep inside the nasal cavity. Epistaxis we can use to find out where is the bleeding vessel inside the nasal cavity, and we use it, of course, to do our cauterization or sphenopalatine artery ligation. In cases of deep foreign bodies, in cases of CSF leak and meningocele, to see the discharge or the leak or the site of the effect sometimes after injecting fluorescein. In cases of granuloma and fungal sinusitis, or to get, of course, biopsy from any tumor of the nose and sinuses. And, of course, in cases of post-operative follow-up, to do cleaning of the discharge and therapeutic uses of endoscopy. That's endoscopic sinus surgery. We have basic endoscopic sinus surgery in cases of chronic rhinosinusitis and polyposis. In cases of mucocele, to open and drain the mucocele, or fungal rhinosinusitis, to remove the fungal material and make good aeration of the sinuses. In cases of foreign body removal and cases of epistaxis, to do diathermy for the bleeding vessels or sphenopalatine artery. We have advanced therapeutic endoscopy in cases of advanced endoscopic sinus surgery. In cases of DCR, bacteriocysto-rhinostomy, that's to open the nasolacrimal sac from inside the nose using the endoscope. In cases of choanal atresia, to remove the atretic plate endoscopically and to dilate the choana. We have cases like reduced blowout fracture, foreign body, CSF leak, repair. In cases of JNA, juvenile nasopharyngeal angiofibroma, and cases of inverted papilloma, cases of other tumors like malignant tumors, cases of orbital or optic nerve decompression. We have also what's called extended endoscopic sinus surgery. That's to remove the pituitary or pituitary gland surgery. Of course, this is very nice surgery to deal with intracranial tumor without open surgery, because this will decrease the morbidity, and we can go through the sphenoid sinus and open the anterior wall. Then we remove the sella or the posterior wall of the maxillary sinus and expose the pituitary gland, and under very good direct vision by the endoscope, we control any pituitary adenoma and remove it completely, securing every bleeding. This is through the nose with very, very minimal morbidity. We can use endoscopy to remove meningiomas or chordomas or very large, difficult, complicated tumors intracranially, craniopharyngioma, orbital apex glioma. So we have many, many uses for endoscopic sinus surgery, whether basic or advanced or extended. Functional endoscopic sinus surgery. What's functional endoscopic sinus surgery, and what are the aims for a functional endoscopic sinus surgery. That's to remove the polypi from the nose and paranasal sinus, aiming to preserve the mucosa, to help the cilia and the action of the cilia, and to keep the patency of the sinuses and suction all the paranasal sinuses. We have new tools which can be used for functional endoscopic sinus surgery, like microdebriders or the shavers. We have the navigation system. All are new tools that can be used and can extend our experience in endoscopic sinus surgery. Complication of endoscopic sinus surgery, we have minor complications like bleeding or adhesions, and we have major or very serious complications like optic nerve injury and internal carotid injury and CSF leak. That's why before we use the endoscopic sinus surgery, should have very good anatomical orientation and very good training and surgical experience, and how to use our instrumentation properly and carefully to do my surgery, getting my aims and avoiding the complications. Thank you. This is the end of my presentation, and thank you very much.